Welcome to our second and last video on miscellaneous immune-mediated skin disorders. Let's begin. Here are the topics we're going to discuss in this lecture. Let's begin with Stevens-Johnson syndrome. We're going to discuss its definition, etiology, clinical features, diagnosis, and management. Stevens-Johnson syndrome and toxic epidermal necrolysis both comprise of a hypersensitivity reaction to certain medications or infections, marked by a widespread painful erythematous and desquamating rash with systemic toxicity. The difference between the two lies in the area of body involved. The term Stevens-Johnson syndrome, or SJS for short, is used when lesions spread over less than 10% of the total body surface area. Toxic epidermal necrolysis is when lesions spread over more than 30% of the total body surface area. Lastly, if lesions involve between 10 to 30% of total body surface area, we call it SJS and TEN overlap syndrome. The drugs known to trigger Stevens-Johnson syndrome and toxic epidermal necrolysis are the urate-lowering agent allopurinol, certain antibiotics including penicillins and sulfonamides, the anticonvulsants lamotrigine and phenytoin, and non-steroidal anti-inflammatory drugs. In addition, infections such as with mycoplasma pneumonia are also implicated. Let's discuss clinical presentation. First, there is a prodrome of flu-like illness comprising of fever, malaise, and headache. This is followed by a rapid onset of painful macules and bullae. The lesions also undergo epidermal sloughing, which can be seen clinically as a positive Nikolsky sign, where rubbing of the skin brings about epidermal sloughing. Here we can see the illustration of a positive Nikolsky sign. Notice how slight rubbing over the lesion makes the epidermal layer slip away completely. The lesions are widespread, and so there is extensive involvement of the skin. Mucous membranes are also involved in the form of oral blisters and erosions. In addition, there is prominent systemic toxicity, and the patients are quite ill. They usually have hypotension, fever, and sometimes altered mentation. Here's an image showing a patient with SJS. We can see widespread involvement of skin with epidermal sloughing and blisters. Here's another image showing a patient with toxic epidermal necrolysis. Notice the extensive skin desquamation. This image is showing oral blisters in a patient with Stevens-Johnson syndrome. SJS-TEN is mostly a clinical diagnosis based on characteristic clinical presentation. It's a life-threatening illness needing aggressive treatment. No cure is available, and the treatment involves withdrawal of the offending agent, hospitalization of the patient, and aggressive supportive treatment with hydration and wound care. Unfortunately, it has a high mortality despite treatment. Next, we'll discuss drug reaction with eosinophilia and systemic symptoms, or DRESS syndrome for short. DRESS syndrome is an immune-mediated adverse reaction to a drug with multiple systemic symptoms. The commonly implicated drugs are anticonvulsants such as phenytoin and lamotrigine, the urate-lowering drug allopurinol, dapsone, penicillin, and NSAID. It manifests as an acute onset of cutaneous eruption, which can take multiple forms including macules, vesicles, and bullae. Accompanied with eosinophilia and variable systemic symptoms include fever, raised LFTs, lymphadenopathy, and facial edema. Characteristically, DRESS syndrome has a long latency period before symptoms develop, ranging from 3 to 8 weeks. This can be a good clue in exam question. This is a child with DRESS syndrome who developed widespread confluent maculopapular rash over his body. DRESS syndrome is a clinical diagnosis. Management consists of withdrawal of the offending agent and pharmacotherapy with antihistamines or corticosteroids. Let's try a question. A 42-year-old woman comes to the physician due to diffuse rash for the past 2 days. She has been taking dapsone and rifampin for tuberculoid leprosy for 2 months. Her vital signs are significant for a temperature of 38 degrees Celsius. Physical exam reveals diffuse macules, vesicles, and bullae, along with generalized lymphadenopathy. Complete blood count shows relative eosinophil count of 15%. What is the most likely diagnosis in this patient? This woman presents with diffuse rash for 2 days. The physical exam reveals diffuse macules, vesicles, and bullae, along with generalized lymphadenopathy. She has a fever with a temperature of 38 degrees Celsius. Complete blood count shows eosinophilia, evidenced by relative eosinophil count of 15%. This patient has been taking dapsone and rifampin for tuberculoid leprosy for 2 months. Systemic symptoms: diffuse rash, eosinophilia, and a long latency period after taking an offending medication suggest the diagnosis of DRESS syndrome. DRESS syndrome is an abbreviation which stands for drug reaction with eosinophilia and systemic symptoms. As we already explained, it can be caused by medications like phenytoin, lamotrigine, allopurinol, dapsone, penicillin, and NSAIDs. Our last topic is vitiligo. Vitiligo is an autoimmune disorder in which destruction of melanocytes leads to areas of depigmentation on the skin. The depigmentation most commonly occurs on the extremities, face, and neck. It can be localized to one area or diffusely involve larger areas of the body. Note that the depigmentation in vitiligo is due to destruction of melanocytes. This is different from the pathogenesis of albinism, in which the depigmentation is due to defective synthesis of melanin, but melanocytes are in normal number. Moving on, vitiligo is a slowly progressive disorder and is associated with other autoimmune disorders, most notably Hashimoto thyroiditis, pernicious anemia, systemic lupus erythematosus, and type 1 diabetes mellitus. Here's an image showing bilateral upper extremity involvement by vitiligo. Note the well-demarcated areas of complete depigmentation. Koebner phenomenon is also commonly seen, which means lesions of vitiligo may appear at previous sites of trauma. Vitiligo is usually a clinical diagnosis. Treatment is with glucocorticoids, which are applied locally for limited involvement of skin and given systemically for more widespread disease. Other options are calcineurin inhibitors and phototherapy. There is spontaneous resolution in a minority of cases. Let's end our lecture with a board-style question. A 55-year-old man is brought to the emergency department due to fever and skin rash for the past day. He started taking allopurinol for newly diagnosed gout 2 weeks ago. His vital signs include a temperature of 39 degrees Celsius, blood pressure of 80/60, a heart rate of 125, and respiratory rate of 17. The physical exam reveals erythematous skin and flaccid bullae involving 9% of his total body surface area. Gentle stroke over the skin results in epidermal sloughing. The painful ulcers are also noted in the patient's mouth. Complete blood count is unremarkable and blood culture is negative. Which of the following is the most likely diagnosis in this patient? A. Vitiligo, B. Stevens-Johnson syndrome, C. Toxic epidermal necrolysis, or D. Dress syndrome. This patient presents with fever of 39 degrees Celsius and skin rash for the past day. The physical exam reveals erythematous skin and flaccid bullae involving 9% of his total body surface area. Gentle stroke over the skin results in epidermal sloughing. This indicates a positive Nikolsky sign. The painful ulcers are also noted in the patient's mouth. Given that he started taking allopurinol 2 weeks ago, he's likely suffering from Stevens-Johnson syndrome, also known as SJS. Stevens-Johnson syndrome is even more likely considering that rash involves less than 10% of his total body surface area, so the correct answer is option B. Here's a slide reminding us of the clinical features of Stevens-Johnson syndrome. Let's discuss why other options are incorrect. Option A is incorrect because vitiligo is characterized by non-inflammatory patchy depigmentation of skin without mucosal involvement. This patient, on the other hand, has flaccid bullae with positive Nikolsky sign and mucosal involvement. Option C is incorrect because although toxic epidermal necrolysis is clinically similar to Stevens-Johnson syndrome, it involves more than 30% of the total body surface area. In contrast, the rash in this patient involves 9% of the total body surface area. Finally, option D is incorrect because although Dress syndrome can occur after taking offending medication, it usually has a long latency period and the complete blood count shows eosinophilia. These findings are all absent in this patient. And that concludes our lecture on miscellaneous immune-mediated skin disorders.